This is another way of the same classification. But if you see the European Association of Urologists guidelines, if the patient is BCG unresponsive, the treatment of choice is basically radical cystectomy. If it is not feasible, then the patient may enroll in a trial, or he may go in a bladder preserving therapy, which has been explained by Shashank sir. Whether there is any option of re-challenging the patient with BCG, there is one option which is given by EAU, that if the disease is high-grade tumor is recurred after 6 months of initial BCG therapy, or if CIS has been recurred after 12 months of initial BCG therapy, then we can re-challenge the patient with a BCG. Late recurrences after BCG or primary intermediate risk tumor, we can use again the repeat BCG, or we can go for radical cystectomy. So why BCG refractoriness is important? This concept is why is talked so much, because the patient with BCG refractory disease had a significantly poorer prognosis than the others. The 10-year PFS rates for patients with BCG refractory, BCG relapsing, and BCG intolerant disease is 53 to 94%. Similarly, the 10-year disease-specific survival rates fall to 62% only with a BCG refractory disease, and that is the reason why BCG refractoriness is very important to understand. So, coming to the systemic option, the one approved systemic option is pembrolizumab, which is an immunotherapy, immune modulator. So, why immune modulator is used in BCG refractory setting? So there is research and they have seen that the patient who received even one dose of BCG, that PD-L1 expression and the tumor suppressive environment of the bladder increases, and that causes a very significant response to immune modulators or immunotherapy drugs like pembrolizumab. So based on this result, the pembrolizumab is tried in a phase 2 study. It's a single arm study, Keynote 057 study. In this study, basically the patients of high risk non-muscle invasive bladder cancer who are unresponsive to BCG and who are declined radical cystectomy, or either they are ineligible for cystectomy, those were the patient population which were opted for this study. There were two cohorts of the study. We'll discuss about the cohort A, which is the first cohort. In this cohort, the patient had CIS and they have this disease is with or without papillary disease. So basically, it's a high-grade Ta/T1 disease. Pembrolizumab is given at the dose of 200 mg 3 weekly for around 2 years. Evaluation was done with cystoscopy as well as with biopsy for initially for every 3 monthly for 2 years, and then 4 monthly for next 2 years, and then once yearly after that. And CT urography was also done to assess the disease status. Now, during the course of the treatment, if there is no no persistence of disease, or there is no recurrence, then the assessment was continued with the same protocol, and pembrolizumab was continued. But during the course, if the patient is developed high risk non-muscle invasive bladder cancer at any given period of time, pembrolizumab was stopped and the patient was followed up with the regular investigations. Primary endpoint of the study was CR, and the second endpoint was again duration of response as well as CR. So what is the important outcomes of this study? At a median duration of 36.4 months, the CR rate was 40.6%. So basically at around 3 years, the CR rate was 40.6%, and the median duration of response was 16 months. Among 39 responders, around 33% of the total population, they remained in CR for 18 months, for more than 18 months, and around 23% of the population remained in CR for 2 years, more than 24 months. Importantly, no patient has progressed to muscle invasive bladder cancer. As Shashank sir said, that when we are using this kind of treatment, it is important the patient may not be progressed to muscle invasive bladder cancer. But during whole course of the treatment, there was no patient who has progressed to muscle invasive bladder cancer. For other subsequent treatments, so what are the other 6 subsequent treatment which is required in the population? Around 31% patients receive additional intravesical therapy. Again, it's BCG only. Around 28% patient had local procedures like TURBT, repeat TURBT, and around 10% patient received systemic therapy, other systemic therapy. if you see the adverse events, majority of patients tolerated immunotherapy very well. The grade 3-4 treatment related adverse event occur in only 12 to 13%. 7% patients discontinued the treatment due to treatment related adverse events, and there was no grade 5 event. So basically there was no death, and there is no conversion of non-muscle invasive bladder cancer to muscle invasive bladder cancer. So this is important because radical cystectomy is one thing which is very morbid to patient. It is easy to discuss, but it is very morbid for the patient, especially when the patient is in non-muscle invasive bladder cancer, and there is very less chances that the patient will die because of disease. The patient has a very prolonged survival. We have seen that 10-year survival is something around 90%, 90 to 91%. So we need to understand, and we have to understand the benefits and the risk of progression to decide whether pembrolizumab we can use or we can't use. Especially if the patient is in dilemma whether to go for radical cystectomy or to wait. This can give us a period where we can wait for the patient's decision and we can continue with pembrolizumab so that the disease may not progress to next step. Thank you.
Thank you, Dr. One patient every month. So with time we understand the biology of the disease. Similarly, this is also a disease where we know BCG refractoriness occurs in the real practice and becomes important to understanding of the methods by which we can preserve the quality of life. Also, Dr. Shashank highlighted other methods as well. Gem dosing, I think intravesical gem dosing is a very good option now, and it has actually helped a lot of patients. Apart from that, there is a systemic therapy option as well. Thank you, Dr. Rahul. So I think